Okay. Good morning once again. My name is Tim Jackson. I'm here with CMS to talk to you all and kick off this webinar. We are talking about reporting MIPS, CQMs, and eCQMs in the alternate payment model performance pathway. This webinar and the demo are specifically targeting the accountable care organizations out there within the Medicare Shared Savings Program. And we are excited to talk to you and to have the opportunity to review some new guidance, which I think provides some clarity, and also present a demo on how submissions function, and then open it up for some Q&A. So I will be kind of the host as we go through this process. And Karen, if we could go ahead and move forward. Next slide. This presentation, again, is a disclaimer here for you. It's a summary that explains aspects of the program, but it is not a legal document. The official provisions are in the regulations, the laws, and the rulings, and we will cover those as we move along. And I do see some folks raising some hands, so we will address questions during the Q&A session. And if you have a comment or question that we can't get to, we'll address that as well through providing a service center ticket. So again, all the folks that you're going to talk to and hear from here on this webinar are experts and very invested in making sure that the Shared Savings Program and the accountable care organizations are successful. Next slide, please, Karen. Here's our agenda. And as soon as I'm done with this, I'll be handing this off to Doug Jacobs to provide the opening remarks. We're going to do a quick review of what's happening here. Sabrina will provide that. Then I will go over the new guidance that has issued this past week. Stephen will provide a submission demonstration. We'll open it up for Q&A and talk a little bit about engagement and resources. So that covers our slide deck for today. From an agenda perspective, Doug, would you like to provide some opening remarks for us?
Sure thing. It's a pleasure to be here with you all today. My name is Doug Jacobs. I'm the Chief Transformation Officer within the Center for Medicare. Making sure that ACOs can report quality in an efficient way is part of our goal to just really drive quality improvement within the Medicare Shared Savings Program overall. And it's just a critical part of it too. And we've gotten feedback over time from folks, some of the challenges that people are facing within their ACOs in terms of submitting some of the CQMs and eCQMs. And so this is one of the first steps of our efforts to really try and make sure that we're providing as much technical assistance as we can, answer frequently asked questions, and make sure that we're engaging in this partnership so that we collectively can improve the quality of care delivered to folks with Medicare. So thanks everyone for being here today. And I'll switch it back to you, Tim.
Awesome. Thanks, Doug. Yeah, so Karen, you can go ahead and advance. We're going to go ahead and move forward into kind of a review. So we know based off of feedback and engagement with some of our ACOs and feedback from our coordinators that we know we expected a few folks to be maybe brand new to this process on the call. So we wanted to give a little bit of the policy and the foundational elements. And I'll turn that over to Sabrina to carry us through this process. Thanks so much. Sabrina, please go ahead.
Okay, thanks, Tim. Next slide, please. So in the calendar year 2021 Medicare Physician Fee Schedule Final Rule, we finalized the Shared Savings Program quality redesign policies, requiring ACOs to report via the alternative payment model performance pathway, which we also call the APP, beginning in performance year 2021. So by requiring ACOs to report via the APP, we reduced the number of measures ACOs report and increased alignment with the CMS quality strategy by focusing on priority measures and improvement areas. We moved the ACO core quality measure set to focus more on outcome measures. We improved alignment and integration with the quality payment program policies and operations. We also reduced burden by leveraging healthcare providers' use of CERT and health information technology. and moved ACOs away from manual chart abstraction under the CMS web interface. Additionally, we improved the quality of care by raising the quality performance standard for ACOs as required by the statute. And we also promoted health equity through measure alignment across payers and patients. Next slide, please. So in performance years 2022, 23, and 24, ACOs have two reporting options in order to meet the quality reporting requirements under the shared savings program. And in this presentation, we will be reviewing and focusing on how ACOs can report under option 1 for performance year 2022. So under option 1, ACOs can report the 3 eCQMs, MIPS CQMs, and administer the CAPS for MIPS survey. CMS will then automatically calculate and score the ACO on the 2 administrative claims-based measures that are included under the APP. So under this option, ACOs will be scored on 6 measures in total. That includes the 3 eCQMs, MIPS CQMs, the CAPS for MIPS survey, and the 2 administrative claims-based measures. ACOs also have the option to report under option 2 that we described here in this slide. And under this option, ACOs report the 10 CMS web interface measures and administer the CAPS for MIPS survey. CMS would then calculate and score the ACO on the 2 administrative claims-based measures. And under this reporting option, ACOs will be scored on 11 measures in total. That includes 8 CMS web interface measures, the CAPS for MIPS survey measure, and the 2 administrative claims-based measures. 2 of the web interface measures do not have benchmarks and therefore will not be scored for performance year 2022. And as I had mentioned earlier in this presentation, we'll be reviewing how ACOs can report under option 1, which is reporting via the 3 eCQMs and MIPS CQMs. Next slide, please. So slide 8 shows the 6 measures included in the APP under option 1 for performance year 2022. This includes 3 eCQMs and MIPS CQMs, a CAPS for MIPS survey measure, and also 2 administrative claims-based measures. Next slide, please. ACOs will be scored on the 6 measures included in the APP under option 1, and their performance on these measures will be used to calculate their quality performance category score under MIPS, which contributes 50 points towards the MIPS final score. Next slide, please. So slide 10 describes the quality performance standard policies for performance year 2022 that an ACO must meet in order to be eligible to share in the maximum amount of savings based on their track and avoid maximum shared losses under certain payment tracks. So in order to meet the quality performance standard under the shared savings program for performance year 2022, an ACO reporting the quality data via the APP will meet the quality performance standard if it achieves a quality performance score that is equivalent to or higher than the 30th percentile across all MIPS quality performance category scores, excluding entities and providers eligible for facility-based scoring, or if the ACO reports the 3 eCQMs, MIPS CQMs, meeting the MIPS data completeness and case minimum requirements for all 3 of these measures, and achieves a quality performance score that's equivalent or to or higher than the 10th percentile of the performance benchmark on at least one of the 4 outcome measures included in the APP measure set, and also achieves a performance score that's equivalent to or higher than the 30th percentile of the performance benchmark on at least one of the remaining 5 measures in the APP measure set. An ACO will not meet the quality performance standard if the ACO doesn't report any of the 10 CMS web interface measures or any of the 3 eCQMs, MIPS CQMs, and does not administer a CAPS for a MIPS survey. Next, I would like to turn the presentation back to Tim to review the new reporting guidance, FAQs, and resources we have available for ACOs.
Thanks, Sabrina. And I just want to again recognize the questions we're getting in the queue. We will make the slides and the recording available. It looks like we have some scoring questions. The purpose of this webinar is really to focus on the reporting. There are resources available, and we'll cover that in a little bit. And I will direct you all to how to find that. It's in the webinar, in the QPP resource library, in the APP toolkit, and that also in the scoring guidance as well. Okay, so now we're going to get into the guidance. It was released on the QPP resource library this week. And so we can go through, we're going to go through 3 different sections. One by one, I will provide a little bit of context and then a little bit of explanation. But for the most detailed explanation, I would reference you to find that reporting MIPS CQMs and eCQMs guidance document that is available in the resource library. And there's many ways to get a hold of that. But we're going to walk through that here and then get towards that demo and then the Q&A. So that's kind of where we're headed. Thanks again for folks that are raising their hands. We want to recognize you, and we'll get to you when we get to the Q&A. When you do raise your hand, we will acknowledge, and you can speak up, and we will answer your questions. So Karen, let's move to the next slides, please. Great. So here we have the reporting for the eCQMs and MIPS CQMs. So, again, we have to start with some ground or base foundation on understanding the APP is reported through the QPP website during the submission period, which is what Stephen will show you in a few minutes. And who does this? The individuals associated with the shared savings ACOs who are the security official or staff user in the ACO management system can access the website using their username and password. For further guidance on how to do that, we have the hyperlink here for an overview, and that tip sheet will explain in further detail for folks that aren't familiar with that. There are other ways to submit data. There is a third-party intermediary, and we'll cover a little bit of that separately. That's using a separate channel, and as well as using your EHR direct, so sending your EHR data directly in to the program as well. So this is, again, the foundation starting point. And for 2022 reporting, that starts on January 3rd. Next slide, please. All right, so here we get into the new guidance we hope is, again, helpful for providing that clarification. So we've had these questions, and we have tailored these 3 elements specifically to assist the ACOs, because we know that this is a challenge. I did see some Q&A comments already speaking to this. So what you need to do as you're identifying that eligible measure population for an ACO can be very unique and very challenging based off of the number of certified vendor products that they're using, the EHRs, also the disparate practices as part of that ACO. So the first step in this guidance document that lays it out, here at a summary point, we're talking about determining your available data sources to accomplish reporting across all participants for the total population. So again, within the policy expectations that Sabrina laid out, it's that total population is what we're looking for. But to do that, you need to look collectively across your capabilities to do so. And then the next step is making sure you have the appropriate collection type for the 3 measures that you may report. So again, there's 2 options for the electronic clinical quality measures or the MIPS clinical quality measures. And then you obtain the patient level data across all participant TINs, CCNs, or other practices according to the measure specifications. Now, this becomes the challenge point in identifying the population. And this is where we're calling out here for ACOs. The patient population eligible for quality reporting consists of the universe of the ACO's participants, all patients, inclusive of patients across participant TINs. So if the clarification is what we're looking to provide is you don't report for one TIN that has the EHR access or one TIN that has this element. It's all TINs. So it is all means all, if we say it simply. But the qualifying element here is after patient matching and deduplication. So this is the question we've been getting, and we're going to speak to that a little bit. But patient matching means, do you have a process and a policy to identify the patient that you're reporting on matches what is consistent with what is in your systems for reporting? So there is feedback we have received on patient matching rates that vary. There is no dedicated industry standard. There are organizational standards, and our expectation is those ACOs have a policy that sets that patient matching and deduplication process in place for them that is consistent with how they operate, number one, and then number two, speaks to those capabilities within the collection types. So I try not to go too fast. We'll unpack it a little bit more in the next couple slides, and then we have a couple FAQs. Next slide, please, Karen. So patient matching and data aggregation. What does this mean? This means you're going to pull the data together by those patients available to accomplish and check what is sufficient for valid and reliable quality measure performance. Is there a dedicated percentile? Is something we've been asked before. And as I just described, our guidance is you will establish a policy to set that is consistent with your capabilities to sufficiently address and ensure that your patient matching and data cleansing are true, accurate, and complete. To remain aligned to the measure specifications through collection, aggregation, and submission, vendors should employ suitable and technologically feasible methods. So that's kind of just restating what I said with a little bit more clarity. Patient matching, parsing, and data cleansing can rely on multiple variables. I referenced previously, some organizations have shown a success rate above 90%. Obviously, the higher number of variables you use for selection, the more accurate your criteria may present itself. That may be a challenge for some systems and some groups that have various levels of that. And we'll provide some guidance on how to address that in just a minute. But again, the ACO should maintain organizational policies to document their approach in patient matching, parsing, and data cleansing. This will be part of any audit. As you'll see in the guidance document, we lay out that process a little more clearly. Okay, this covered our kind of the midpoint. Now we're going to move to the last item. Next slide, please, Karen. So data completeness. This is where what you provide to the QPP production system with your submission during the submission time period matters. And so all of the elements that we just referenced are guidance to help with the kind of the before. Once you get into the submission process, data completeness is where you have sent what you are saying is true, accurate, and complete. So that is 100% of your eligible and matched patients according to the policies that the ACO has. Then that data must meet the completeness threshold, which is 70% for 2022 and 2023 performance years. This threshold increases to 75% for 2024 and 2025. So the data completeness threshold is set at 70% and grows to 75%. So it's getting more rigorous in the future. This means that the performance data of measure met or not met, which is the measure denominator exceptions, would be present for at least 70 or 75%. There are plenty of guidance documents that present how this occurs. We do lay this out as a process for more thorough understanding in our guidance document that may be of use for some. Now, in the case of eCQMs, they are specified to be calculated using all patient data and submitted electronically without manipulation, with exclusions of certain cases that are not already locked in with the code and the measure specifications. So ACOs, just like all MIPS groups and MIPS clinicians that submit an eCQM via certified EHR technology or CERT, would achieve 100% data completeness by virtue of sending an eCQM with end-to-end electronic reporting. So let me just state it again. Data completeness using one method has a threshold of 75 or 70% based off of the year it's reported. If you're using those eCQMs, the expectation according to our policies and certified EHR technology is that achieves 100% data completeness. Incomplete reporting of measures, eligible population, or otherwise misrepresenting a clinician or group performance would not be considered true, accurate, or complete. And again, that speaks to what is submitted to us and is attested to during the submission time period for the quality payment program is kind of a lock. And that is how we continue to hold it as we move forward and take that data and then use it for not only MIPS scoring, but as Sabrina described, also the ACO quality performance assessment. Next slide, please. So this is our FAQs. These are pulled directly from tickets that we have received. I'll try and move through these. I know we want to get to the demo and questions. So the first question we have is, are specialist patients included in our eCQM and MIPS CQM measure submissions? So unpacking this question in a different set, I have cardiologists or pulmonologists and primary care, internal medicine. Who needs to be in my measure submission from a provider and beneficiary or patient level? When reporting at the ACO level, again, as we mentioned and provided for in policy and in other guidance, you're reporting on behalf of all participant patients, which depending on the measures denominator may include patients of specialists. So this means that your submission should include aggregated, eligible, and matched all patient data for all clinicians from the ACO participant TINs in the ACO. So this means any specialist patients that meet the measure criteria. So back to the use case, if the cardiologists or pulmonologists are included in that measure criteria and the ACO has them in their TINs, the expectation is yes, they would be included in the measure submission. And the ACO, again, should coordinate with the providers inside and outside the ACO to meet the numerator criteria. That does require significant work. We did have ACOs successfully do this in the prior year, and we have heard from them on the kind of cadence of doing that. It took some time, but once the process was established, it did have very good effects. So I would encourage you to reach out, and we'll cover that in the resources. But this has been done successfully. It does require some work contextually, but is it required? And the answer here is just assuredly yes. Is it achievable? And I would also say the experience that we have heard from some ACOs is yes, clearly. Next slide, please. This is our second FAQ. This is speaking back to the patient matching and data aggregation. So ACOs should submit QRDA1 files for every patient associated with this. So no, this is kind of confusing things a little bit for folks that aren't aware. So quality reporting data architecture 1 versus QRDA 3. So QRDA 1 is for hospitals, and QRDA 3 is what is submitted for the quality payment program into the production environment. So that satisfies the collection and submission type. QRDA 1.4 again is for hospitals. That is one way that the ACO can participate to get patient level data. However, again, only QRDA 3 or JSON files are accepted. That doesn't mean that you're not using QRDA 1 files to build your collective eCQM submissions. There are many examples of organizations and ACOs that have been pulling these together as part of their policies and process to do so. And the ACOs should implement formats and processes that best fit their workflows. We have had, and there are some experiences on how to do that. And again, that falls within the expectation of your policy answering the question as to how you would do that with a level that makes sure it's true, accurate, and complete. Next slide. Data completeness. So here we're going to give it a wrap and get ready to move into the kind of the more engaging parts of the this webinar. The ACOs can submit a eCQM if some participants do not have CERT. So the answer is very clear. This is driven by our policies. No, all participants would need to use CERT in order for the ACO to submit via an eCQM. For an ACO not prepared to report via an eCQM, the MIPS CQM collection type would be the only other option to report the 3 quality measures under the APP. So let me unpack that really quickly. If the ACO has multiple certifications and some practices with no certifications, and those practices had measure inclusion, contacts with patients, then to be true, accurate, and complete, and to have achieved their data completeness, they would not be under the CERT standard. They would be under the MIPS CQM standard, which is 70%. If they, and we'll probably get that question a few ways here in the Q&A, but MIPS CQM measures allow for the use of multiple sources, including multiple EHRs, paper records, registries, and patient management systems to compile a measure's numerator and denominator. Individual patient data is matched and deduplicated by the organization, the registry vendor, or the ACO populating those MIPS CQMs. And that format is provided in JavaScript object notes or JSON. MIPS CQMs cannot be submitted in QRDA3 format for benchmarking and scoring. Again, JSON is how you send a MIPS CQM to the production environment, and Stephen will show us that in just a few minutes. However, eCQMs can be submitted as a JSON or QRDA3 format for benchmarking and scoring. And this is something that is very detailed and explained in the QPP developer tools site, and we'll cover how to get to that here within the resources. Okay, next slide, please, Karen. Go ahead. So we have 4 items here. Just wanted to highlight. The number 1 is the QPP resource library. If you are not familiar with that, you can just Google that right now. Near the top of that resource library page, if you just type in the title of this webinar, you will pull up the guidance document that is provided and referenced. We will also include that for the attendees, and so that folks have that hyperlink as well. Again, it was posted just this week. For our ACOs and the ACO management system, they can also get the specific guidance reports and knowledge sharing that is available. And it is a really outstanding resource, a great way to not only get access to the libraries of information that are there, but also to begin to contact the coordinators and a little bit of the broader sense of what's moving for the program in other capacities, both on the financial and the participation sides. Visiting the eCQI Resource Center. This is for very specific questions on eCQMs. And we are not specifically addressing the derivative elements of eCQMs in this. We are talking about the submission guidance to help with the factors we have addressed for very specific eCQM criteria. There is a lot in that resource. So I would, if you do not have a technical background or you're not already working in a technical shop, just make sure you talk to someone who is very familiar with clinical data architecture. Finally, and this is the broadest point of contact, is our ACO coordinators and the Quality Payment Program Service Center. This is our go-to start point for anybody who is trying to get answers, trying to get started, or really trying to get ready for submissions, and they don't know, what is available, what are the checklists, what are the process, what toolkits are available. Send that inquiry in, start digging through some of these resources. We want to help. There's a whole team out there that's looking to help you. Okay, next slide. So we're going to pass this over to Stephen, and I'm going to let him take it away for the demo. Thank you. Stephen.
Hey, thanks, Tim. Let me get my screen pulled up. So essentially, this is going to be starting after the point of all of the topics that Tim went over of getting your submission ready, and the submission period is open, and now you are ready to report your data. Again, this would be at qpp.cms.gov. As Tim mentioned, if you're looking for information, the resources, the resource library, this is where you would go. If you're signing in to report, you would go to this page, which would take you to your login information. After you sign in, you would land on our starting page, which looks like this. So you'd see something letting you know that the reporting window is now open. You're able to start reporting for performance year 22. So once I go into here, this page is going to show me all of the associated entities that I have. So in this case, I'm associated with one APM, and I'm going to go into start reporting. So at this point, there has been no data submitted. It's the beginning of the submission period. You would land on this reporting options page that essentially gives you the ability to either report to traditional MIPS or report to the APP. Since we're discussing the APP, we're going to go down this pathway. So we're going to start reporting. You're going to get met with this modal letting you know that you're reporting to the APP and are agreeing to be scored via that mechanism. And this will take you to your reporting overview. Again, there is no scoring information. There's some generic data on here about what the categories are, but you won't see this updated until you've actually submitted something. So I'm going to go ahead and upload a file, which is the QPP JSON. And you can see that this was successfully uploaded. In the instance that it was not, you would end up with a red message box here letting you know that something is wrong. And you can download the information associated with that, which will tell you exactly what the problem is. But once I go to view results, you can see that this page is now populated with information. My quality score is populated. This is done in real time based off of the information that's been submitted. Since you have reported data, you can see as well that you're getting these 20 points for the improvement activities category. And then if we want to go in and view the information associated with my quality score of what I just reported, this is what the page looks like. So you have the 3 measures that have been reported that are associated with the APP. And within each one of these, you can open them up. It gives you more information about what's been reported. So you have your eligible population, your data completeness, and then the denominator. And then you can see how it's being compared to a benchmark and being scored associated with the information. So again, based on the underlying data that's reported, which I will pull up in a minute to show you, again, you'll see your eligible population, the data completeness, and then your numerator information. And then in the instance where you have reported less than the eligible population, you can see my data completeness has gone down to 80%, my denominator is 80, and my numerator is 80. So the eligible population, again, is reflecting all patients that are eligible for the measure based off of the reporting data. During the submission window, we also have these measures that are associated and available, just letting you know that they're calculated after the submission period closes. However, these are the 3 measures that could be applicable. In the instance that one of the administrative claims or both are not available due to not meeting the minimum requirements, after the submission period, those would not count towards your score. CAPS is required, so if this is not reported, it would result in a score of 0 out of 10 for the category. And then at the bottom of the screen, you can see here that we have our category score over 60, which is the number of required measures times 10, multiplied by our category weight of 50, giving us a score of 20.14 out of 50 for the quality category during the submission period. So if we want to look at the information of the underlying data that has been reported, you're going to see something that looks similar to this. So this is the QPP JSON format that Tim was mentioning. This is how you would report the information. This is the structure. You can see the measure ID, the underlying components of performance met, not met, eligible population. This would be your submission method. If you're reporting the CQM version of the measure, it would be registry. And you can see that you have to indicate your program name with APP1 for the measurement set data. Again, this would be after you have compiled all your results and have gotten ready or are ready to report. This is what it would look like uploading to the UI. If you are using a QRDA3 file for upload, it would be the same process as I showed, and it would upload and show the same information. Where it really deviates on the requirements for submission is if you are using the API to report your data. So that's the other option. I know that some of the ACOs that are using the web interface have utilized the API for submission to the web interface. This option is also available for reporting to the APP outside of the web interface. It looks a little bit different because, again, the data elements are not the same between the web interface and the requirements on reporting the APP. So this is basically what you would be reporting. Again, you would have this would be pointed to production. You would go through the same process as you go through currently to get your token, where it would go through the auth API endpoints. You would get back your token, which then would allow you to report this through the API in a programmatic fashion. You can see that the structure of this is different from what is uploaded to the UI, because we're starting with the measurement set, which then is going to be linked to the entity being reported. And then you have your measurements that are actually being sent through. So if I go back here and I delete out this data, which you can see by going to manage data, clicking on delete and deleting, I'm now at this point where I have no information that has been submitted. So if we go back to the reporting options page, if you were coming in and have a vendor or you have reported via the API, you would see that it says edit submission. And if we go back to the API itself, if I send this through, you can see that this is then giving me a 201, letting me know that my request has gone through. I have information associated with my submission. So if you're looking to get your score, you can post to the score endpoint, which will send you back the response in JSON format. But if I go back to the UI, and if I go into edit submission, you can see again, my score is now available. It's been reported via CQMs, and it's letting me go through and look at the same information that we were viewing previously. Again, it's going to be laid out based off of this. And of course, if you have reported something and you would like to delete it out, that is always an option, where as long as you have reported the data and it's coming from the same token, what you would end up doing is going to the delete measurement set endpoint, taking your measurement set ID and sending this through. If you get a 204, that's letting you know that it has actually been processed. If I go back and refresh the screen, you can see that the data then again is not available. There is no reporting information. So whether you're reporting via yourself through the API or if you're using a vendor, that information would be controlled through the backend services if they are using API. There is also information on the resource library around using the endpoints. So if you have questions about that underneath the developer tools, there's information around utilizing the submissions API. There's documentation. We have Swagger information that's available, which is similar to what has been provided for the API related to the web interface. But this has lots of really good information if you're looking on ways to programmatically set up your submission and allow for your organization to report via that mechanism. The difference again between reporting via the API and the UI, if you use the XML file or the QRDA3 on the UI, it will actually send it to the conversion endpoint for you, which converts it into JSON that gets submitted to the submissions API. And that's in an automated fashion. If you are using the API itself, you would need to use the converter endpoint to convert your QRDA3 file into QPP JSON in order for you to use the API. If you try and submit the QRDA3 directly via the API, it will fail because it will not recognize the data elements required. That, from a high-level perspective, is what the APP reporting would look like outside of the web interface for ACOs within the QPP site. And I will turn it back over to you, Tim, and stop sharing.
Thanks, Stephen. Marv, this is the time we want to go ahead and get ready to prep the poll questions. Karen, if you could start sharing again. Thanks so much, Stephen. That was awesome. I know that for folks that don't have a technical background, what Stephen showed you is literally what you can do starting in multiple points within the program in that production system. But as early, on January 3rd, you can go in and submit, right? So for ACOs that may be considering how and what they're going to do, if you've already committed to the web interface, makes sense. You can also go in and go ahead and submit in a couple different formats if your vendors support that, so you can see the results. What Stephen was showing you was your real-time results. What he showed you is the same thing you can see given the access that you already have with the submission and collection types already available to you. So I want to make sure that that is very clear, right? So he's not showing something you can't have. That functionality, you will see those results as they are there. Now, they are not the final results, as Stephen said. Those don't happen until they get to the preview and final scoring later in the year for 2022. But again, starting January 3rd, you can get in there and start looking at this and understanding it, getting familiar with it. I think we do know that a lot of ACOs and their either their vendors or their EHR teams are pretty familiar with this, and so they are not unaccustomed to going and doing that research. So we would expect that you'll be able to, number one, partner with them to get that. And then number two, you can go ahead and start pushing those questions that make sense into the service center. We will not be able to answer a lot of the technical questions here once we get in, which is why I'm kind of pausing here for the engagement. We do have a quick couple polls we want to run for our participants this morning. So Marv, can we go ahead and set those up? Thank you. We're going to give it just a couple minutes here for folks to take the time to look at the questions, and then we will take that feedback as a great indication. And thank you for your participation and for responding on the poll. I know that not everyone will be able to stay for the Q&As. So. Mark, can you double check? I think on my side, it says that the poll was ended. Might just be my view.
I noticed that as well, Tim, that it went away.
Yeah, it dropped off. Let's just double check.
Yeah.
Okay, there we go. I think it's live again. Let me check the participants. There we go. Yeah, thank you so much, Marvin. Thanks, Stephen, for reconfirming. Thank you, everyone, for hanging in there. We'll let it run for another minute to make sure we're getting some feedback. And I do see a few folks raising their hands, so hopefully we answered that one. And we're going to wrap the poll up here in just 30 seconds. Want to make some time for the Q&A. Thank you. All right, thanks everyone. I'm going to go ahead and close the poll and we're going to move to a couple of elements and then open it up for Q&A. So I just want to make sure folks can see. We did get some good feedback. I think the majority of folks responded. So, you know, about 40% of folks plan on getting into the eCQM, MIPS CQMs here this next year. 84% of us are looking at doing this in 2023 and 2024. And the resources that seem to be most useful are what we're doing now with webinars and user guides. So thank you for that feedback. And finally, and this one I did see from a couple of folks in the chat and Q&As already, an open source tool for patient matching and data aggregation. I see an overwhelming response there. So thank you so much, everybody, for helping out with the polls. I'm going to stop sharing that one. And we are going to go ahead and move to the next item for today. Go ahead, Karen. So we want to cover the learning system. For folks that aren't aware, we have an opportunity for getting ACOs to improve their delivery of care through the learning system. We did have a presentation that I referenced previously with ACOs sharing their experience on the 2021 reporting. And the materials from that webinar can be found in the Knowledge Library. Search for the SSP ACO Learning System webinar strategies for eCQM reporting. There'll also be further announcements for that ACO Learning System. And again, that tool and capability is focused and solely for ACOs. So we will go ahead and next slide, please. All right, so at this point, we're going to set the real quick review on ground rules and turn it over for Q&A. Next slide, please, Karen. So to ask a question, raise your hand. Someone will be able to unmute your line and you'll be submit your questions via the box. If you'd like to ask a live question, please recognize you need a working microphone. And speakers will address as many questions as time allows. We have about 10 minutes here. And we do want to take that opportunity. We do have measure subject matter experts, submission subject matter experts, ACO program subject matter experts. And if we can't answer your question, we will ask you, respectfully to send that in as a ticket or follow up with a coordinator afterwards. We don't want you to feel like you're not being heard. Number one, we do want to hear from you. And number two, we know that some people may come with very specific questions or guidance they want immediate resolution on, and that's not always available. So we just want to be cognizant of that and respectful of our time together. So I'm going to go ahead and turn it over. Marv, can you help with managing I think there's a few folks with hands up, so I'll turn it over if we can go ahead and do that. Thank you.
Thanks, Tim. Miriam, your line is unmuted.
Hi, Miriam, please go ahead.
Hi, can you hear me?
Yes, yes.
So I guess I'm wondering, are most people using vendors to be able to coordinate? Our ACO has multiple EHR systems and they aren't communicating. So is that our best bet? I'm not very technical, so I guess we're needing some help.
Yeah, thanks, Miriam, for the question. So I'll start, and if others want to provide some feedback. We do have the team in here that does work with the vendors or third-party intermediaries is the term we use for the programs as they submit to the quality payment program. That is an option, particularly for the disparate or systems that may not have fully updated and aligned cert. They are going to be using that vendor to help with the data collection, the data parsing, and the data aggregation. Those vendors have a bit more information and capabilities. They, from an ACO perspective, they've been doing it in MIPS for about 5 years, right, Miriam? So some of them are well equipped to do that. Some of them have been working with ACOs also. So there are some opportunities there. That list of resources is in the guidance document, and you'll also find that on the QPP resource library. So, and you can contact those organizations directly. And there are also other ways to reach out to them. So please do so. Thanks so much.
Thank you so much. I appreciate the information. One of our issues is that one of the EHRs doesn't even support one of the measures that's required. So it's been a difficult go for us.
Understood. Yeah, I would definitely recommend reaching out to get that support and information. And again, you have some time to do it, as we saw with the polling. You know, some people are ready to do this very quickly, and it sounds like you guys are still in an assessment mode. So reaching out is it will take some time and effort, but it will pay some dividends. I would help it, particularly for that one practice for you. So thank you so much, Miriam. Let's go to the next question, please, Mark.
Amy, your line is unmuted. Amy Carver, your line is unmuted.
Hi, I don't have a question, so sorry.
Thanks, Amy. You're you might want to take your hand down. It's you're raised on the webinar. Thanks. Got you.
Sandra, your line is unmuted.
Sorry, I clicked raise hand by mistake.
Thanks, Sandra.
Tia, your line is unmuted. Tia Salvor, your line is unmuted. Rick, your line is unmuted.
Yeah, can you hear me, Mr. Jackson?
Yes, Rick, I can hear you.
Yeah, Rick Bukowski from Eastern Virginia Medical School. I have 2 questions. First of all, I've been a qualified registry submitting MIPS for some time. So I think from what you all are saying, an ACO entity can submit themselves, even if they're not a qualified registry or an EHR. That's one question. So we can get on this QPP site, and if we can get the data in the right JSON format and either upload a file or use the API, we can submit as an ACO ourselves. That's one question. And then the second question is, like, we also have several practices on different EHRs. Most of our participants are on one big EHR, Epic. So, but we don't have all of the data. We can match the data, we can deduplicate the data, but we don't have it in 2015 cert. So if we did CQMs, could we identify the eligible denominator for the patient measures, the patient denominator, using a combination of EHR codes and pre-adjudicated claims from the other practices to determine the 100% denominator, and then try and meet the 70% numerator just on clinical data? Is that one method to go to do that using CQMs?
Yeah, great questions, Rick. I'll answer the second one first. The answer is that is and would be conforming to the guidance that we're providing. And that would be, you can use any combination of data that provides that sufficiency for the what is expected for the collection type of the MIPS clinical quality measure, MIPS CQM.
Okay.
For your first question, Stephen.
Yeah, I can
Yeah,
I
or,
got
or
it.
Damon probably. Damon,
Sure.
please.
So that is correct. You do not have to be a vendor in order to submit your data. If you have the ability to upload the file, then as an APM entity or ACO, you can do that yourself.
Now, but even for eCQMs, I thought you had to be 2015 cert vendor to submit eCQMs, or are you just referring to the CQMs for us to upload the data ourselves? Because I mean, really, you have to get all the data out of the EHR without any manual manipulation and submit it. So I'm trying to think how we would do that as an APM entity. We'd have to get a vendor to do it, wouldn't we?
As the eCQM requirement is it must be end to end and originate and come from 2015 cert. So if there is any type of manipulation or aggregation that is data outside of those, you would need to report it as the CQM version of the measure, not the eCQM version.
Okay. Yeah, that answers my question. And I think this is a point that's not clear. I mean, if we've got 5 EHRs, none of these EHRs are doing it for us. None of us are putting it all together and doing it. And since you have to be 2015 cert to do it without manipulation, it's going to be kind of hard to do those eCQMs unless these EHR vendors start changing their tune. But anyways, that you answered my question. I think CQM is going to be the way to go, and I appreciate the information. This has been a good presentation. Thank you.
Great, thanks, Rick. We are at time. I do want to see, Marv, we'll just do one more question. And for folks that have their hands raised, I provided the guidance previously. Go ahead and send a service center ticket. If you have something in the Q&A that's not answered, pull that back out and send it to us. We want to answer it. We will keep a collection of those Q&As, but let's just do one last question, please, Marv. Thank you so much, everyone.
David Mayo, your line is unmuted.
Thank you, and thanks for hosting this. I actually have 2 questions as well. Is there any pressure being put on all the EHR vendors to actually do interoperability by the government? Is one, and then the second question is, who can we just report on who we consider to be our patient panels? Especially with primary care, access is such an issue these days. And we just can't see everybody all the time, and so they're limiting their patient panels. Is that, for example, the population we would report on for this deliverable?
Great questions, David. So for the first one, yes, there are many ongoing discussions. I'm not sure if you're familiar with the Office of National Coordinator. Or how EHRs were designed and how they developed over the past 10 plus years. But the Office of National Coordinator is responsible for certification. And we do look to that organization for the standards that the EHRs need to apply. They do certify those EHRs, and that certification then allows them to be previously eligible for a lot of financial incentives and support working with providers and hospitals. And now within the QPP program, that trusted certification is what provides confidence that what they are providing is true, accurate, and complete. So that's how they get to 100%. The second question, I want to make sure that I'll try and, because I know we're a little past time. We do have several examples, and there are some processes in place, but the reality and the clarification, and we covered it previously in the demo, is that the panel is not the limiting factor for measure inclusion of a patient. So, for some organizations or some people still with us on the call, you may have a primary care provider with 5,000 patients impaneled. If they see somebody that's not on their panel, did they contribute to the measure? Should they have been screened for, behavioral or blood pressure? The answer is yes. So they would be included because it is all patients, not just impaneled only patients. But I think that you have posed a great question. It is something that we are looking at as a program, but as the policies are provided and as the guidance we have reviewed, it's not exclusive to a panel. So I just want to make sure that that is clear. And I still see quite a few in the Q&A, but unfortunately we are past time, and I know a few folks are starting to drop off. If we could just, I'll just go quick close. Last slide, please, Karen. Okay, so we do have some opportunities for engagement as part of that polling question, and we will provide some updates on that. Thank you so much, everyone, for participating and hanging on. We appreciate your feedback. We appreciate those questions, and we look forward to further engagement. I wish you a great Thursday, and look forward to seeing those submissions starting in January. Thank you, everyone, and have a great day.